Good morning again, everyone. My name is Jennifer Howard. I'm with the Turner Senior Wellness Program. I am very happy to introduce Dr. Tamarelli and Dr. Marcos this morning from Michigan Medicine, who will be talking to us about depression and anxiety in older adults. And with that, I am going to go ahead and turn the lecture over to both of you.
Sure. Thank you, Jennifer. So it's such a nice pleasure to be here, and I know I don't have a chance to see all of you out there, but thank you for listening in. We're happy to be here and talking this morning. So what we hope to do here is share a little bit about how we as psychiatrists conceptualize depression and anxiety in geriatric population, some of the factors that are involved with symptoms, diagnosis, and share a little bit about treatment options as well. So I'll share a little bit of background about us. So I realize you can also see little squares of our faces there in the video, but I'm Nick Morcos. I'm a geriatric psychiatrist at the University of Michigan. I did my training in psychiatry and geriatric psychiatry here at U of M, and now assistant professor, and my clinical work and research interests are involve mood disorders, geriatric psychiatry, things like depression, bipolar illness, things like that. And Dr. Tamarelli is one of our budding geriatric psychiatrists. She's a third-year psychiatry resident. I'll let you introduce yourself briefly, Carrie.
Yeah, I attended University of Michigan for medical school and stayed on for residency, and I see patients 1 day per week in our geriatric psychiatry clinic.
Yep. So we'll go ahead and get started. So thinking about where to begin with this big topic. So what I want to do is share a few statistics that really hopefully drive home some of the real world issues here in making the diagnosis and treatment of geriatric depression. And the reality is that most older adults who have depression are unlikely to ever see someone like myself or Dr. Tamarelli. They usually don't see a psychiatrist at all. In fact, most people go to the primary care setting. And among primary care visits with older adults, about 5 to 10% of those involve an assessment for depression. We see, though, that patients who have depression who are going to their primary care doctor, it's really often poorly recognized. And even those who are recognized as having depression, a lot of them still don't get adequate treatment for that. And so this is really contributes to a big health issue. And there are a number of factors that are involved with this, and we hope to dive into a little bit of that. So here's a cartoon that illustrates at least one of these potential problems, which has to do with stigma in treating mental illness. So this is maybe relevant in the COVID times, right? Unfortunately, when folks are being very seriously ill and hospitalized, but this is someone saying, geez, cheer up, have you tried not being in a coma? But then the caption here is, if we treated other ailments like mental illness, right? And so there are probably, stigma is maybe one issue why folks don't see psychiatrists, but we hear all the time that people, misconceptions like this. I should be able to pull myself up by the bootstraps, right? This is just a sign of weakness, or there's nothing wrong. I should be able to shake it off. So afraid maybe to acknowledge that there are problems, seeing it as a sign of weakness or vulnerability, stigma, of course. And then a part of the issue also that the cartoon doesn't highlight, or these misconceptions don't highlight, is that depression actually can look different in older adults compared to younger counterparts. And so things like feeling sad or depressed may actually be not as common, whereas not having that motivation or drive to be doing things, not getting pleasure out of things like one used to, those are more common than just feeling sad or depressed. So what we want to do is give a little bit of background in terms of psychiatry and our where we come from in terms of our treatments, to help put things a little bit in context and maybe even highlight why older adults may have misconceptions about psychiatry or mental illness treatment. And so the first idea, of course, is that depression, even though this is more of a modern term and descriptor that we use in modern medicine, the concept is really not new at all. And it's really been described even in ancient times. And the term melancholy comes from the description of black bile, which is this idea that there were humors that circulated through the body and influenced mind-body illness and interactions. So this is even a very ancient concept. This is we'll show, Dr. Tamarelli and I will show a few. I like to have some paintings and artwork here through the talk. So this is a work by Albrecht Dürer from 1514. So really many centuries ago, called Melancholia, and just really conceptualizes very well how distraught and sad. I mean, everybody looks in this painting, right? The people and even the animals and the baby. But this is very classic Dürer. I don't know, Dr. Tamarelli, if you're familiar with his work, but really very detailed. Yeah.
Always impressed by how he manages even to make that, like, I think it's a cow.
I know, yeah, on the bottom left there.
So sad.
Yeah. Anyway, so moving on a little bit. So like all areas of medicine, psychiatry has had, unfortunately, its fair share of less than reputable folks in the past and providers, probably more so even than other areas of medicine. That has to do with really the lack of understanding that we've had from a scientific standpoint about what's happening with the brain. This is really just one example, but this person, Wilhelm Reich, had this idea that there were such things as orgones, which were this hidden energy source that was kind of flowing through the body, and when it would be constricted in some abnormal way, that would lead to mental illness. And so he would devise these boxes and blankets and different ways of trying to help these orgones flow smoothly to treat depression. And he was shut down eventually by the FDA for, they decided that this was fraudulent activity. He ended up claiming that he could cure cancer by doing things like this. And this was in 1947, which really, is fairly recent in the grand scheme of things, right? When you think about modern medicine, I mean, a lot of advances in other fields by the 40s and 50s had been, much further along. Of course, this is really a notorious and dark chapter in the history of psychiatry. But here again, just to emphasize that this is really in, relatively recent times. This is Antonio Moniz, who's a Portuguese physician who really popularized lobotomy. He actually won the Nobel Prize in Medicine in 1949. And so, of course, this is like I said, a very dark chapter in the history of the field. But what it does highlight is that it was a shift in thinking from these spiritual or orgones or some mystic kind of explanation for things toward more of an anatomical explanation for mental illness. So if there's any, there's highlights, I guess, that the transition in the thinking and the research at the time. Here's another painting we can share, Dr. Tamarelli. So this one is by Van Gogh. It's called The Asylum Garden at Arles. It's 1889. And this was actually while he was a patient there. Really, the idea with asylums highlights just the lack of available treatments at the time. And so unless families were wealthy enough to provide care for a loved one at home, oftentimes people with severe psychiatric illness or other neurological illnesses would end up in an asylum. I want to show, this is a quick timeline that I came up with here to highlight really the recency of medications in treating mental illness. So here you have, back in the era of the asylum, you had things like morphine and opiates and chloral hydrate. These were basically just sedating medications, really not designed to be treating the underlying illnesses that people had. Meprobamate, 1950, this, the thinking is that or Valium, those are medications that were really popularized by the Rolling Stones with the song Mother's Little Helper. But those are really in the 1950s that you had the advent of these sedative type medications. Chlorpromazine, which is the first antipsychotic medicine to treat illnesses like schizophrenia, that's again 52. That's Thorazine, which is something we don't use commonly nowadays. But here I show imipramine in 1958. That's the first antidepressant medicine. And this is really pretty modern times. Prozac, which really kicked off the era of modern antidepressant medications, is 1988, which is the year I was born, actually. So that I don't know if that makes me maybe less credible with the audience, being a younger person, but really Prozac was the first of what we call SSRI medicines, which involve really more precise way of addressing depression in the brain. And that after that time, there have been a real surge of similar medications that developed and are still being rolled out to this day.
Yeah, and so I think with the development of these medications, in the last 70 years or more, psychiatry became an increasingly medicalized specialty. And, the DSM-3, or the third edition of the Diagnostic and Statistical Manual, spearheaded by Robert Spitzer, really marked a transition from primarily, Freudian psychoanalytic ideas to diagnoses based on clusters of symptoms. I think the important thing about this, the DSM and kind of using symptom clusters, was that it really enabled researchers and practitioners to start speaking a common language and begin to systematically study different types of illnesses to determine what treatments might be effective. And so, this more medical approach to depression, anxiety, and other psychiatric illnesses has really revealed that these conditions not only have, social and psychological roots, but biological ones as well. And, scientists have been able to demonstrate discrete changes in brain function and structure in different psychiatric illnesses. And so, modern psychiatrists now really use evidence-based treatments whenever possible, meaning, these therapies have been studied in groups of people and shown to be, more effective than placebo. And so, although we don't always yet understand how or why these changes are happening, we've studied the brain of people with depression and know that there are a number of changes that happen. Some of the key areas which are highlighted in this drawing are the medial or sort of central part of the prefrontal cortex, which is the front part of the brain highlighted in purple. And it's responsible for, sort of the executive functioning or higher level control of different brain processes. Depression also involves the amygdala, which is kind of the red-orange part deep in the brain, which is a really important part of the brain that scans the environment for threats and can produce strong emotional responses. And so we know that there's these structural changes as well as alterations in the neurotransmitters, which are the chemicals carrying messages throughout the brain. Changes in hormone regulation. I think a lot of people have heard about cortisol, which is a stress hormone. Changes in the immune system, sleep physiology, which might be why some people with depression just can't fall asleep at all, and others really need a lot of extra sleep. But we've really been able to see that this all happens in the brain of people dealing with depression.
You mentioned that, yeah, that's very important about how it affects the whole body. And you talked about the immune function, and there's a lot of theories about the role of inflammation in contributing to depression. And along those lines, where you see folks who have autoimmune diseases or conditions like that affect the inflammation in the body, that they often have a higher likelihood of having things like depression or anxiety or sleep issues. And so even though some of these areas are poorly understood, we do know that these changes do occur.
And so, whenever we start talking about these brain changes and people thinking about symptoms they've had or people they know, people often wonder sort of, when do my changes in sleep or changes in mood sort of cross that line and become a mental illness or, clinical depression with a capital D. And this little cartoon has a man or person on an analyst's couch saying, lately I'm feeling kind of downcast, despondent, if you factor in the wind chill. But, in psychiatry, we're really looking at the clusters of symptoms and then asking, are these symptoms causing significant distress and or impairing functioning? And, sometimes that can be hard to distinguish, especially during the pandemic. I think has been a great example of, many people dealing with sadness from loneliness or grieving the death of a loved one. And I think we would argue that it's not pathologic to feel down or struggle in these situations. And someone dealing with sadness or grief might have thoughts like, I miss my loved one very much, or it's really difficult not having them here with me right now, or I'm having a hard time because things have changed so quickly. But in depression, often these thoughts become more extreme or distorted. So like, I'm going to feel terrible forevermore, or everything that happened is my fault. And these thoughts, might worsen that distress or make it hard to function in day-to-day life. And we might call that depression. And a key point of all of this is that depression is not a normal part of aging. I think sadness, grief, again, suffering and hard times surely are part of the human experience and might even be more common as we get older, but really those more extreme symptoms of depression are not typical. So what is depression, and sort of what are those more extreme symptoms? This is another painting by Van Gogh from 1890, Old Man in Sorrow. In psychiatry, like Dr. Morkos was saying, especially in older folks, sometimes it's not that sadness or feeling blue, though depressed mood can be a key symptom of depression, but it might also just be that loss of interest or pleasure in activities, which we call anhedonia. Or it might be feeling worthless or bad about yourself. And then these sort of core symptoms are usually accompanied by a number of changes in sleep, so too much or too little, changes in energy, so either being really fatigued or having a lot of nervous energy, changes in weight, so losing appetite or maybe kind of overeating, craving a lot of comfort foods, changes in concentration and memory. And especially in our older patients, they might worry that, like, am I developing a dementia? The symptoms can be that severe, but that we find by treating depression, we actually are improving those cognitive functions.
Okay, so this is a little transition slide, how to get up and get dressed. This is someone who's really struggling. This is obviously meant to be comical, but this is really how a lot of patients feel when they're struggling with depression, just having that lack of motivation and drive to get up and do things like they used to. So another important point that we wanted to highlight is that depression, as with a lot of things in psychiatry, but depression in particular, tends not to exist on its own in isolation. And depression and anxiety in particular really go hand in hand. So about half of depressed older adults also have an anxiety disorder, and about a quarter of those older adults who have an anxiety disorder develop depression at some point. So the two really are expected in many ways to co-occur. Dr. Tamarelli, like you mentioned about having that kind of nervous energy or sleep problems, those also are often symptoms of anxiety issues. And so they can be difficult to tease out and separate, or they often co-occur. This is a little bit of a cluttered diagram, but I want to highlight that there's not one type of depression, right? So when we talk about older adults who we see in the office and who we're evaluating for symptoms of depression, we're really asking a lot of questions and reviewing their medical history and labs and all these sorts of things, trying to tease out, well, what's the best or most accurate descriptor of this type of depression, because it has implications for how we might consider treatment. And it's not, we don't mean to go into the details here, but I show this as an example of some of the different ways that we conceptualize depression. We still use, you'll notice the term melancholic there on top. That's still a term that, even though comes from more ancient times, it's still something that we use to describe certain symptoms in depression. You may notice also seasonal depression there on the left. And of course, living in Michigan this time of year, this is when we're asking patients about exposure to light and getting outside and being active, and how that can impact depression. Dr. Tamarelli, you mentioned about grief, and certainly there's a normal component to grief, but it also can be what we term kind of a complicated grief, or where that really bubbles over into depression. And there are, of course, other descriptors here. I also want to emphasize that depression, while it comes itself in a number of different forms, it also doesn't exist in a vacuum. And so we talked about anxiety briefly, but a lot of patients who have depression, especially if it's a recurrent illness throughout their life, they often have difficulties with one or more of these other conditions. And we see commonly people have PTSD symptoms or related to previous traumas in their life. Some patients can have what we think of as a persistent depression, meaning instead of these discrete episodes of feeling down, they may just kind of go through many years where they're just on a mild or low level of depression that seems to hang around despite treatment. Anxiety disorders are, of course, very common. And then we worry about substance use issues. even in older adults. And the ones that we see more commonly tend to be alcohol misuse and prescription medications. So we see sometimes patients who struggle with things like pain medications or anxiety or sleep medicines. And then, of course, being in geriatric psychiatry, we're always on the lookout for cognitive disorders. And we know that depression and certain forms of dementia can often go hand in hand. So what are some of the factors that go into influencing depression? Again, this is a bit of a cluttered slide here, but I'll just go through. If we look here on the left at some of the biological factors, there's really a number of things that seem to play into the development of depression or the risk of somebody having depression in their life. Part of it seems to be genetic, and I don't mean that there's one specific gene or mutation or something that causes somebody to have depression, but it's really a very complicated interconnection of many genes, and we really don't understand too well. But what we do know is that depression does run in families. We see it more commonly in women. We see also other biological factors that put somebody at risk. So certain endocrine disorders, things like diabetes. We talked about stress hormone levels being factors in development of depression. Cardiovascular disease is really important in older adults, and we see that depression levels are really higher in patients who have had strokes, heart attacks, even things like mini strokes or TIAs that seem to put folks at risk of developing depression. And some of the other psychiatric illnesses we talked about in the previous slide. And then there's also psychological factors and social factors that have to do with development of depression. Part of it can be personality based, and we know that people who are more prone to being what in earlier times folks would describe as neurotic tendencies, or being more anxious, meticulous, detail oriented, those sorts of folks, they may have done very well. It may have been very helpful in their careers, and oftentimes those sorts of things can be harnessed to be helpful, but we do know that it can predispose somebody to be at higher risk of developing depression. Stressful life events, we mentioned the role of traumas and PTSD being often co-occurring with depression. And then stressful life events in the moment, so things like financial strain, low socioeconomic status, relative social isolation, or limited family or social supports is also a very important risk factor for depression in older adults.
Yeah, and I think, Dr. Morcos, you mentioned a lot of these biological or medical conditions that can increase risk of depression. And just to highlight, a couple that are more common in older adults, heart disease or heart attacks and strokes seem to precipitate depression in some people, but other chronic, conditions that are really common, like diabetes, sleep apnea, especially if it's not treated with a CPAP or other type of breathing machine at night, and kidney disease, all seem to increase your risk of developing depression over time. And you may remember that I mentioned earlier kind of extreme types of thinking that can transform, for example, a process of healthy, normal grieving to something more like a clinical depression. And we call those thoughts cognitive distortions, because they tend to be sort of twisted or extreme in various ways, such as, all or nothing thinking, or overgeneralizing, or really personalizing problems, feeling like everything is your fault. And so what we know is that, thoughts influence the way you feel, the way you behave, and those can all start reinforcing each other and actually make it harder to get out of a depression without some type of intervention, either in addressing or changing those thoughts or behaviors to help you feel better. That being said, there's also a number of factors that seem to increase someone's chances of recovering from depression, and that includes abstinence from substances like alcohol or other illicit drugs, employment, which doesn't necessarily just mean a job, but in retirement or otherwise being engaged in activities like volunteering, caring for grandchildren, other community activities. For whatever reason, women and extroverted people, perhaps because they're more likely to reach out for support, whenever the depression was not precipitated by a major life stressor, that seems to, if it's something that sort of evolved over time. And a lot of these are not in your control, but the last one on this list, adherence to treatment, is one way that you can have some control or increase your likelihood of recovery. But interestingly, amongst older adults, actually the strongest predictor of recovery is involvement in a spiritual or religious community. And a lot of the patients that we see, that is a real strength of theirs, is being connected in one of these types of groups.
Yeah. And like you said, Dr. Tamarelli, a lot of these things are, things that may be outside of one's control. But one other point I would make is that getting treatment started early is also a really important predictor, because we see that folks who have depression that's persisted for longer periods of time, it's much harder to treat and takes longer usually to respond to things like psychotherapy or medications or other kinds of interventions. So adherence to treatment is big, and also getting treatment started early if you can. So putting it all together, right? So we've talked about a lot of different factors that can be involved, and really, our role often in psychiatry is trying to get as much of a history and background, reviewing medical illnesses, reviewing things like family history, previous life experiences, stressful current events and stressors that may be happening, because all of them can be potential areas for intervention in developing a treatment plan with somebody. So just to highlight a couple more, one is that the perceived social support is really a robust predictor of late life depression. So, again, that emphasizes some of the difficulties that people have been having with the pandemic in the last year and being socially isolated. But we know that older adults who have more in the way of social supports, family, friends, otherwise could be, community settings, religious groups, whatever it is, they seem to be at lower risk of developing depression. And physical illness, especially in older adults, is another stressor that can lead to severe depression. Again, part of our role in psychiatry is working with other physicians in screening for and helping to really optimize other conditions that affect depression. So like you said, Dr. Tamarelli, things like sleep apnea, right? Screening for that and treating it if it's there. Helping people to be motivated to maintain good control of their diabetes, right? Or keep their blood pressure under control, or cholesterol. All these things really impact the way that the health of the brain. And physical pain is another one that's also important in terms of risk factors for depression. And a lot of times our treatments can be designed around helping to address depression and pain as well. So this is just to illustrate what we hope to have described, is that there are so many factors that go into the development of depression, all of which can be potential areas for intervention. And really, people who do the best in terms of recovery and treatment approach depression treatment from more than one angle. So I'll let Dr. Tamarelli share some initial areas that are helpful.
So, whether you're worried you might be becoming depressed or developing anxiety, or maybe you've been diagnosed or you are concerned about a loved one, there's a lot of things kind of you can do to start feeling better that don't require a prescription. And we're going to kind of start by talking about some of those. And so, really the first step to make sure your brain function is getting back on track is ensuring that you're really nourishing your brain and body and providing it with the nutrients that it needs. And so most of the studies about diet and mental health have showed that really a varied diet, so kind of sometimes people feel like they've gotten stuck in a rut of eating the same thing every day, but a varied diet rich in protein, fiber, and folate can really ensure that other treatments for depression will have their best chance at success. And often older adults ask me sort of what they should eat to preserve their memory. And the good news is that kind of the diet with the most evidence for reducing the risk of dementia, reducing the risk of stroke, as well as depression, is a Mediterranean style diet, which is really rich in unsaturated fats, protein, fiber. And there's a lot that you can sort of read on the internet or ask your primary care doctor about to sort of learn how you can make sure you're incorporating those foods. Another sort of free, it doesn't have any side effects. I think we all know that physical activity and exercise is really a wonderful way to help your mind and body be its best. And so, I think I encourage people to exercise and whatever exercise they'll actually do. So finding whatever's fun and knowing that this will really has evidence to reduce depression, increase your brain volume, quality of life, mobility, and even can delay the onset of dementia. For most seniors, kind of moderate activity levels are the way to go. And that means 150 minutes per week. Dr. Morkos did this math for me, and that works out to about a 20-minute walk every day. And that can be as effective as a medication for depression. And I think it's not always easy to start out, if you haven't been exercising, but sort of gradually building up to that goal of 150 minutes per week can really make a big difference.
Mm-hmm.
Another treatment that a lot of people are, I think, surprised or don't think about when we recommend to them is light therapy. And so, light boxes or therapy lamps can be purchased from a lot of brick and mortar stores around town or online. They used to be really big and bulky and have these expensive bulbs that would burn out. But now most of these lights use LED technology and are relatively cheaper. And can have a lot of benefits, again, be as effective as a medication for helping with mood, and not just seasonal or wintertime depression, but year round. And it can also help regulate sleep. So how do you do it? We recommend you try to find a 10,000 lux lamp and sort of read the manufacturer's instructions, which will tell you how far it should be from your face, usually about an arm's length. And you don't look directly into it, but it should be kind of shining directed at your face, and using that for 20 to 30 minutes every morning is a good place to begin.
Mhm.
Next is psychotherapy. And I think it used to be that really the only type of therapy that was offered was psychoanalysis, which was really typically a longer kind of intense course where you were, sitting on a couch stereotypically, and that is still a treatment that's available. And in Ann Arbor, we have a lot of great analysts in town. But there's also newer types of therapy that are available, and they're really intended to be short term and kind of help pull patients more quickly out of a depression or treat anxiety. And these focus more on the here and now as opposed to your past. And they might even use things like worksheets or homework to help you sort of maximize your benefit between sessions. Because usually practicing these techniques for an hour per week is probably not enough. But by practicing them every day, you can learn some techniques and sort of change your habits and ways that will help more quickly. And this is really sort of an alphabet soup of CBT, IPT, ACT. So, there's many styles of therapy, but kind of the one most commonly practiced with a lot of evidence is cognitive behavioral therapy, or CBT, which is based on that idea we were talking about earlier, that thoughts, emotions, and behaviors can all affect each other and either reinforce a depression, or we can kind of use it to our advantage to kind of tweak things and improve depression and anxiety. So there's other options though, like I mentioned, IPT, which is interpersonal therapy, that's particularly helpful in transitions. And so, at our clinic, like many others in town, we offer sort of group formats of some of these therapies, which are sort of more like a class where you learn about the techniques and can practice on your own, or work with an individual or one-on-one therapist that's kind of like a coach to sort of help you practice and incorporate these techniques into your life.
Mhm. And a lot of people are apprehensive about the idea of groups, but that seems to be really where a lot of the benefit is derived in studies of therapies. And it has the added benefit of adding that social aspect that seems to be helpful in treating depression. So we talked about psychotherapies a bit, but the modern psychiatrist has also shifted away from that antiquated sort of model of the couch, right, and sitting there, and of course we still pride ourselves in being empathic and understanding and really getting to know our patients well and understand their backgrounds and exactly what sort of struggles that they're having currently. But it's really not just that. We also want to be, we're physicians, right? And so, like we've emphasized, our role is often in addressing all of these components that can impact depression. And so screening for and helping to address these chronic medical illnesses that play a role, or can even in some cases mimic depression. So Dr. Tamarelli was a little bit uncertain if I should show some of these slides, but I decided I'll do it just so you in the audience, you can see that these are what our articles look like, our evidence-based research studies. But what I want to emphasize here, just a word about medications, is that since I showed that timeline of development of medications in psychiatry, since Prozac came about, these have really blossomed in that time. And these are what we consider more modern antidepressants. And in this graph, this was a study that looked at many compilation of results from many studies and tens of thousands of patients. And the verdict is that each and every one of these is effective, superior to placebo. And so all of them are going to be effective antidepressants based on population studies. And what that means is that they're tools in our toolbox to potentially help people. It may be that we, if we meet with somebody and decide that medications may be helpful to them, certain among these may be preferable based on someone's medical issues or sometimes particular symptoms that they're struggling with. But there are many options that exist. And so I find this to be a very reassuring figure. Same thing here. Again, this will not, there's no homework or quizzes on this lecture, Jen, so you don't have to, the audience doesn't have to worry here. But this is a very important study that basically highlights one of the essential treatment philosophies and understandings that we have, and that is that people do well when they have, we're talking about more moderate severe depression, people do well when they have medications, people do well when they participate in psychotherapy, but people really do the best when they combine both. And so when people have more severe symptoms, we really, again, the data is telling us that we need to be thinking about approaching it from different angles. And again, this is not to say that, out there, if somebody, has symptoms of depression, that, medication is the right answer or this type of therapy is the right answer. What we hope to emphasize is that really there are a number of options that are out there available to us, and really part of our role is to help to decide with the patient based on their symptoms and their medical struggles, what's the best plan that's going to be effective for them. So a few take-home points here, and then what we'll do is open it up to questions. But depression is common. Many factors seem to influence it. Of course, there are some changes in the brain and in the body that we've hinted at, and we often, we didn't get into too much depth, Dr. Tamarelli, about things like neurotransmitters or, inflammation or hormone levels. And the reality is that a lot of these things we know are changes in the body and associated with depression, but we still have a lot of ways to go in terms of understanding how is it that those changes actually produce the depressed brain, right? So there's still a lot of research to be done. Depression is treatable, but really early intervention and active involvement is best. And people who I see who, like you were mentioning, Dr. Tamarelli, who get themselves active, they're exercising, they're using the light box, they're socializing as best they can. Maybe it's through Zoom or things like that now, or making phone calls to family, but they really seem to do well. And there are, of course, as we mentioned, there are a lot of things that people can't do on their own. I do want to add to this, though, that we talked about people going to their primary care doctors back on one of the first slides, and that's fine to do. That's a good first step. We'd rather have people discuss concerns about depression with somebody, right, instead of trying to go and struggle on their own. And a lot of times, primary care doctors are very savvy and skilled in working up depression and coming up with initial treatment plans that are usually good. And if there's still struggles, then we at the Geriatric Center, we're available for patients, and we often see patients as referrals to their primary doctors. So that's often a good place to start if there are concerns that people have. I do want to thank Jennifer for inviting us to speak today, and thanks to the Turner Resource Center in general for all of the great programming that they do, and some of our mentors and colleagues at Michigan Medicine who aren't around here today, but who have helped with our training, and colleagues of ours, things like people like Mary Blazek and Sue Maxner, who are really instrumental in our department. So with that, I'll see if Jen has questions from the audience, and Dr. Tamarelli and I will do our best to try to field those.
Okay, excellent. Thank you so much, both of you, for an excellent presentation. Again, for our participants, if you have a question, you can type it into the Q&A box at the bottom of your screen. I do have one question, and that is, as depression is anger turned inward, how does one get rid of the anger? Psychotherapy?
Yeah, that's interesting. Maybe this is someone with more of a therapy kind of background. That's conceptualizations of depression that are really based on that kind of analytical model. A lot of times, therapy could be helpful for that. We usually, whether it's CBT or otherwise, we do know that, as I was showing in that last graph, that psychotherapy is helpful for depression. And usually what we're doing is less about making a distinction about the foundation, I guess, of some of those cognitive distortions, and more recognizing that, yes, they exist, and then helping somebody to work through them in therapy. So the analysis component could be helpful, but also I think that the behavioral therapy side of things could also be helpful for it. Sometimes if people also, I'm going to just one more comment, Jennifer, but a lot of times if folks have that kind of irritability or frustration or anxiety piece that goes along with the depression, there, other aspects of treating depression is also going to help it, right? So that could be medication, it could be exercise, it could be light therapy. Yeah.
Okay, excellent. Thank you. Dr. Tamarelli, did you have anything you wanted to add?
No, I agree. I think it's a good question, and we often, that internalized anger or self-loathing or is not uncommon. Certainly not everyone with depression feels that, but many do. And I think any of the treatments that we offer to help with depression would help with that. But I think psychotherapy definitely is one great option.
Okay, great. Thank you so much. The next question, actually, there's two questions in this question. Do you accept patients without referrals for evaluations? And are there any medical study programs?
Yes, we do take, people can call in to schedule an appointment. So we're talking about the geriatric psychiatry department which is housed at East Ann Arbor Medical Center, which is off of Plymouth Road. And you can call and make an appointment. Usually our patients are 70 years and older. But if you're interested, the number for our clinic is 734-764-6831. I can't make promises about our wait list or things like that, but yeah, you don't have to have a referral. And there, part two, remind me, Jennifer.
Yes, that was about if there were any medical studies.
Yeah.
Right now. Let me get the exact one. Are there any medical study programs?
We do offer some, there are some ongoing studies for depression through our colleagues at the Rachel Upjohn Building, which is in adult psychiatry. And some of our patients may qualify for things like that. clinically at East Ann Arbor, Dr. Tamarelli, I'm not sure if anyone is running studies currently.
I'm trying to think. Yeah, there's always, I think often if you qualify for a study, your physician will be sort of notified and will ask you if you'd be interested in learning more about the study. But yes, there's some that kind of come and go. They'll be recruiting new patients. And so if you're one of our patients, you would be potentially notified if you qualified for something.
Yeah. What I would say is if somebody's really interested in participating in treatment through a research project, the way to inquire about that would be through the Rachel Upjohn building, and which is the home of our ambulatory psychiatry. And that's 764-0231.
Okay, thank you. The next question is, can you comment on holistic ways of treating depression, mindfulness or massage, how effective compared to other methods of treating?
Dr. Tamarelli, do you want to start? Or?
Sure. So, I think we could talk a lot about all the different sort of holistic approaches. And I think we chose to talk about a couple of those or non-medication options. The amount of evidence we have for different methods like massage are variable. So we tend to, in our clinic, focus on holistic methods that have good evidence. Mindfulness in particular is one that does have a lot of good evidence, and actually there's a mindfulness-based cognitive therapy that specifically has most evidence for when people have recovered or maybe have just a mild depression, sort of maintaining and preventing slipping back into a more severe depression. And we offer a group in our clinic for that mindfulness-based cognitive therapy technique. Happens to be one that does have a lot of evidence, but I'd encourage anyone who's considering a holistic or sort of complementary or alternative strategy for treating depression to really do some research or potentially consult with someone who has read the literature, is aware of the evidence, just to make sure. We always want people to be getting their money's worth or know sort of what the potential benefits are. Many of them do have good evidence, but many don't.
Okay, thank you. The next question is there any developing mental health information or treatment for Parkinson's patients?
Yeah, so Parkinson's disease, and we see and treat a lot of this in our geriatric psychiatry clinic. There's a lot of overlap between patients who have Parkinson's disease and depression. And it's really to the point where we even think about it as being, a component of the illness itself. There are a number of things that can be helpful. So exercise in particular, we really think about, like we were showing, just for anyone with depression, it's very helpful, but patients with Parkinson's disease in particular, it's so critical to be physically active and moving to help with all of the movement issues with Parkinson's. And Tai Chi in particular is actually really evidence-based in that population for helping with mobility and balance. But again, there's going to be benefits for mood also. I'd say also that there are, if somebody with Parkinson's disease is struggling with more, moderate or severe depression, where we're thinking about medications being useful, then we also know that there are certain medications that seem to be more safe and helpful in the Parkinson's population. Certain among them even seem to be helpful with treating some of the movement aspects of Parkinson's. So it's certainly something we see commonly, and there are really some specific treatments that we might recommend medication-wise or exercise-wise.
Okay, thank you. Somebody wanted to know for a referral for age 50 years plus, would that be Upjohn?
Yeah. Yep.
Okay.
Yeah, 70 or younger. If the caveat there, and we didn't talk about it today because we're focusing on depression, but if there's a younger person who has a diagnosis of dementia, then they would be eligible to be seen at East Ann Arbor at the geriatric clinic.
Okay. All right. Thank you. Somebody had commented, just said U of M Health Research will send emails about different studies. I think if someone goes to their website, they could sign up to be contacted at U of M Health Research.
Okay.
So,
Yeah,
yeah.
that's a good point. They do have a website where you can kind of enter certain demographic things, or and you potentially would be contacted even if you're not a current patient at any of our clinics, but you're eligible for a study. That's a good point.
Okay, fantastic. So that is the end of the participant questions. I have a question for you that maybe you can help with, because I think it's something that we hear a lot about. What are your recommendations if someone has a loved one who they think is suffering from depression? How do they open up a conversation about that with their loved one? Any recommendations on how to address that, how to, especially if they're fighting perceived stigmas and that type of thing, how do they help a loved one get help?
Do you want to start off?
Sure, I can
I'll
start.
jump in.
I always encourage family members or friends who are starting a conversation to begin often even just practicing like the first thing you're going to say. So a phrase I often encourage people to use is like, I'm concerned because I've noticed, and just sort of, sharing what you've observed in a non-judgmental way. Like, I've noticed, you are spending more time in bed and don't seem to be enjoying yourself, or and just starting from that place of love and concern, and really letting your loved one kind of lead the way as to what they think might be helpful, offering to accompany them to a appointment, or can we call together your primary doctor, or maybe you used to see this therapist, do you think maybe we could call them again? But sort of just letting them know that you care and you're there with them, I think can go a long way.
Yeah, I completely agree. It's hard. You can't argue with somebody when they're just sharing their own experiences, what they notice, right? And like you said, as long as it's coming from a place of caring and compassion, you're doing the best you can. And encouraging to go to the appointment is so important. Again, I have no problem with people going to see their primary doctor first, right? Because that's usually a less threatening environment. Often that's a relationship that the person has had with the doctor for many years, right? And just to emphasize again, just how commonly we see this, and the primary care doctors, this is, I can guarantee it's something they see on a daily basis. So it's not something that would surprise them or make them think differently of anyone.
Okay, wonderful. And this may be a harder question to answer, but maybe the answer is somewhat similar. But how does somebody motivate themselves when they're feeling depressed, and the depression itself is so, makes it that much harder to reach out for help? And maybe the conversations are somewhat similar, the non-judgmental sort of conversation you have with yourself, but any recommendations for people in terms of how to get themselves to get over that hump and actually ask for help and talk to their primary care doc?
Yeah, we talked about how a core feature of depression, right, can be that low motivation, low energy. And yet we also say that a key predictor of recovery is being active and involved. And so it's really hard when the illness itself can get in the way of treatment. And so, there are some techniques that can be a place to begin. One we call behavioral activation, which is sort of can be a number of different techniques, but a way that I might encourage someone is kind of pick one thing to do. So instead of thinking like I'm going to cure or solve my depression this week, is starting with one thing. And maybe that's calling your primary care doctor to make an appointment. Maybe that's calling a friend just to share with them how you've been feeling. Or if you're concerned about a loved one, maybe it's helping them say, let's, do this one thing together. But sort of just picking one thing, one place to begin and doing it. Sometimes, by checking that one thing off a list, someone might feel a little more confident that they're able to do one thing tomorrow. And maybe that's getting out of bed and getting dressed. And they find that helps them feel a little more awake or like themselves. So that would be maybe a piece of advice I'd give someone, is just to pick one thing.
Mm-hmm. And it's the same even when folks come to see us and they're maybe ambivalent about treatment, or because of the symptoms of depression, it's really difficult for them to be motivated or have the energy to do things. And so a lot of what we do is work with people where they are and set those small goals. And the idea is just getting traction, right? Like you're saying, Dr. Tamarelli, getting the ball rolling, even if it's very small steps at first.
All right. Thank you. Thank you both so much. I think that is the end of our questions. One of our participants did say we are lucky to have your psychiatric services in this area. It's hard to find psychiatrists in other areas of the state. And I would agree. I think that we're all lucky to have you in the area. And I know Ann Arbor tends to be pretty rich in resources, especially through Michigan Medicine. So that's fantastic. But thank you so much for your time, for a wonderful presentation today. For all of our participants, Dr. Marcos and Dr. Tamarelli will be back with us on May 8th to talk about personality disorders. So we're really looking forward to that conversation. If you'd like to attend and haven't signed up yet, you can go to MICHMED, michmed.org/TSWP for Turner Senior Wellness Program. And with that, we will conclude. So thank you all for participating. Thank you, Drs. Tamarelli and Marcos. And everybody have a great rest of your day.
All right, take care.
Thank you. Bye-bye.